Foundation. This is a symposium about snakes and snake bites. Why are we interested in snake bites? Well, snake bites are a neglected tropical disease, according to the WHO, because snake bites cause mortality and morbidity across the tropical regions of the world. We are in the tropics here in Eswatini, well, on the edge of the tropics, and yet 20 years ago, we knew nothing about snake bites in this country. It took the tireless workings of a very energetic and multi-talented young lady, Tia Lichka-Kun, to demonstrate to the country that we have a serious problem with snake bites. She established the Eswatini Anti-Venom Foundation, specifically to deal with this issue of snakes and snake bites. We love snakes, but we do not want snake bites. And Tia has dedicated her entire life, when she is not already working on other things, to this. Some 500 people report snake bites to the EAF, Eswatini Anti-Venom Foundation, every year. That's just the number that report. So you can imagine, in this tiny little country of 1 million people, we have a lot of people that are being affected by snake bites. Of those 500, approximately 100 of them need antivenom. Antivenom is not cheap. Antivenom is not easy to get hold of. Again, EAF has made it their objective to make sure that antivenom is available for anybody that requires it. Some over 4,000 victims of snake bites have received assistance from the EAF in the last 15 years. That's an incredible number of people that have been assisted. The EAF also has an outreach program. It's reached over 70,000 children, bringing the message about snakes and about prevention of snake bites. Some 217 schools have been visited. That's almost 1 in every 4 schools in the country have been visited by the EAF. On top of that, the EAF is involved in research. You'll hear some of that later today. The research involves critical things like the epidemiology of snake bite, like the effectiveness of antivenom, testing the different types of antivenom to see which ones are effective and which ones can be brought into the country to treat this. There's also other kinds of research, like understanding the relationship between the human environment and the presence of snakes in that environment. This is a subject that borders between ecology and the human dimension. To that end, we've put together a database of several thousand snake records to map the distribution of every species in the country. And this is a database that can then be used to do all kinds of ecological applications and so on. So I'm not going to say any more. I'm not one of the experts. My name is Ara Monaghan, by the way. I'm a professor at the University of Eswatini. I'm very interested in snakes. I'm very interested in ecology and how we can mix all of these. But the real experts are here, and you're going to hear from them during the course of the day. I just want to ask, please, to have good phone etiquette. If you have a cell phone, please check that it is on silent, because I know that no one will switch it off. At least have it on silent so we don't have cell phones ringing in the middle of the sessions. When the experts are presenting, we will not field any questions directly. However, your questions can be sent to a WhatsApp number. That number should be in your starter pack with you. If you have any questions, please WhatsApp it to the number that you were provided. That number, that person receiving that will make sure that the panelists at some stage will address your questions, because there's question and answer time available. There's also a lot of time in the late afternoon, evening, when the panelists are going to be around that would love to speak to you. Approach them, come and talk to them about anything you would like, and feel free to mix and mingle. So with that, I would like to, where is this young lady? Okay, so I'll hand over to this not so young lady, Chris, but Tia is going to do the welcome, but Chris wants to say something anyway.
Yeah, I identify as a young lady, all right? Is that all right? Thank you. Am I welcome? Tia, please come up here. You see this beautiful creature on my shoulder? This is more so for our panel of experts, especially Tia. And it's our time controller, all right? So that's why this TikTok is on my shoulder. Tia?
Thank you. Morning, everybody. Welcome for joining, or to join us, or being here with us today. We're excited to see so many people have turned out. We're here to learn. We're going to focus on several aspects of snakebite. That includes the medical management, general awareness. We're going to cover for the very first time snake bites in animals. And we're also going to have a live session with our panel of experts for the EMS staff that are here today. Welcome. In our community, we have snakes. We live with snakes. We live in Africa. We don't live in a bubble. So we need to make sure that the people who are affected by snake bite receive the best treatment possible. Snake bite is a neglected tropical disease. It's the most neglected tropical disease of all the neglected tropical diseases. Snake bite is on top. And nobody's talking about snake bite because it doesn't affect the policymakers. It affects the poorest of the poor. So thank you for being here. Please become our ambassadors and spread the word. Let's stop the suffering. We've also got a live feed. So we've got people that have logged in from all over the world today. So we have to keep time because everybody's waiting for their session to come on. Okay. All right. So we have a panel of trustees. I'm the founder and chairperson of the Antivenom Foundation. My late husband, Clifton David Kuhn, was a founder. With me, we've got Dr. Jonathan Pons. He didn't make it today, unfortunately. He's been admitted, he's ill. We've got Alvin DuPont, who's our legal representative. And the last trustee to join the board was Dr. Sarah Padida. She joined us in 2019, and her role is research director. Clifton was an integral part of the foundation. He traveled with me, he caught snakes, he hated snakes, by the way, he was petrified, and he's the only person I could never teach to actually hold a snake. In 20 years, my only failure, and he will be my only failure. Okay. Our panel of experts, I'd like to introduce Professor Oro Padida. Sorry. It's because your wife confuses me. Okay. So Ara Monaghan, he's a professor at the university. We've got Arno Nordia. Are you here, Arno? Okay. He's going to be talking about challenging snake bites. Dr. Bongi. Okay. She's from RES, good friend of mine, and has been working with me to perfect the treatment of black mamba bites. Chris Hopkirk, we all know Chris. You'll get to know him. Please take him with a pinch of salt. Okay. Dr. Christoph Bell, he's going to be talking about the medical management of snakebite today. You need to know him. Any questions, please ask the panel. You're more than welcome. We're going to mingle. Come and talk to us. Just be respectful. If they are talking to somebody else, just give them a few minutes, please. Dr. Gabriella, she should be sitting with a panel. Dr. Gabriella, you should be sitting with a panel. Okay. She's going to be covering the snake bites in animals today. Dr. Gabriel, he's from MSF. He'll be joining us online. There might be a change in the program for his presentation. Sarah will explain. He's got a deadline today. Dr. Hugo, the man of the moment. This man is phenomenal. This doctor knows his stuff. This is EMS, treatment, you name it, Hugo's your man. Okay, so for all the EMS staff, please talk to Hugo. He'll be doing a practical session here with us today, and he's going to be teaching you how to keep somebody alive until we get them to a hospital. We've got Dr. Jessica. She's joining us online today. She'll be also discussing treatment in animals. Dr. Jonathan Pons, unfortunately, isn't here. Jonathan Leeming. This is the spider guy. He likes things with 8 legs. We prefer those with none. Okay. So he's phenomenal with snake bite, spider bites, scorpion bites, and very importantly for us here in Eswatini, centipedes. We're very worried about centipedes here in Swaziland. So he's going to explain there's nothing to worry about. Okay. Then last but not last, Nick van der Walt. Thank you for joining us. Our family's back together again. You're a new member of our family. Welcome. He will be doing the pre-hospital management of snakebite, and he'll also explain the use of these beautiful flipper cards that you have in your bag. Okay? Oliver Kuhn, missing in action. Oh, there he is. He should be on the panel of experts too, please. All right, he's going to be doing the snake awareness course for you today, together with Zakele. Dr. Praise hasn't made it yet. He's still on his way. From Dr. Praise, please can you join the panel? And Dr. Tenda, please can you join us? Sorry, they lost. And then, of course, me, you know me. All right. Professor Timothy Hardcastle is joining us online. He's going to be talking about the management of snakebite in pregnant people, the elderly, and he's also going to be covering the surgery of snakebite. Surgery and snakebite, I think everybody on this table here, we're very conflicted, but it needs to be discussed. Dr. Sarah Parida, you my angel, my girl. Okay, she has saved me many, many times. Last year was a really difficult year for me, and she kept the boat afloat and kept us on course while I was trying to find my feet. And last but not least, Zakele. He's running around doing his thing. He's standing outside. He's going to do the snake awareness course for us in Siswati. All right, TikTok. This is one panel member we haven't discussed. TikTok has traveled the world. Okay, I'll tell you about TikTok. So he started in Corsica. I was invited to the Eurovenom conference, and they had TikTok there as a timekeeper. This is how it works. 5 minutes remaining. For the panel member and anybody who's asking a question in your sessions, 5 minutes remaining. This is 2 minutes remaining, panel members. Okay? All right? And the timekeeper is coming for you. We're going to grab the mic from you. Okay? The only exception is myself. All right. That's the timekeeper. All right? He's in charge of TikTok. He tackles rhinos. So don't think you can match him. Okay. All right, special mention, Britton Watts, he's not here today. He extracts venom from our snakes. Unfortunately, He's working. My son Nathan and my brother Martin, they're around here somewhere, also working. Roxy and Tom. And then, of course, Carrie, my makoti. Okay. She's my makoti. She's joined the team. She's a Santon girl. Never touched a snake before. But she's getting there. Thank you very much. You've bailed me out again and again. All right, and very special mention, our team, our family, the EAF community. We've got 140 volunteers out there removing snakes, and we're doing this to prevent the human-snake interaction, and we've seen a significant drop in snakebite, but not only that, the outcome of snakebite has improved because the community members are there with their community, they're advising on the correct first aid, they're helping us transport the patient to a hospital, they're doing a tremendous job. They're volunteers, they don't get paid, and if we can give them a clap, if you don't mind. All right, so in your book of goodies, you've got the program. Okay. So we're all going to be sitting here until tea time. We're going to be covering the following subjects you can all read, I'm sure. Then we're going to have morning tea here. Then we're splitting into various groups. We've got the snake awareness course, which will be taking place just next door. The medical management course is in the actual reptile center, in the room where the snakes are. And all the puff adders are giving birth, by the way. Oh God, I've got 2 minutes, okay? And then we've got our veterinary group. And then we're going to do the EMS here, as I've said. All right, then we're meeting here again after lunch to finish off. Please remember we've got a creepy crawly walk with Jonathan today. He's going to go find us some critters. Okay? I was petrified of spiders until Jonathan taught me that I have nothing to fear. Okay? I was phobic. Okay? And he got me over that. Thank you, Jonathan. All right. There's also a cheese and wine afterwards. If you want to stay around, we're going to serve a bit of cheese and wine. If you would like to stay after the presentation, you can meet the panel, have some discussions, and then we're going to do the walk. We're also going to have live snakes on display. We will be sharing the tasks. Some people will actually be holding the mamba, so you can actually touch it yourself. They'll also be on the floor, so you can have a good look. All right, let's interact today. Let's get over our phobia. We've covered all these points with the prof. The only thing is, if you have a question, we don't have time to answer questions as we go along. Please use that WhatsApp number. Send your question to that WhatsApp number. Then it will work. It won't work. Okay. Please take down the following number for your questions. 7602 5088. 7602 5088. Okay. Thank you to our sponsors. We couldn't do it without you. The Times of Eswatini, Enviro Applied Products, Emafini, Mbluzi, Beef Boys, UVS, Happy Valley Casino, Elite, Luxy Garden, and Proper Meats, and one anonymous sponsor. Thank you very much. All right, so that's my session done before Chris tackles me. Oh, sorry, I'm back.
Yeah, while you sort that out, let me burst your eardrums. We've got 1 minute while Tia sorts out her presentation, which will be identifying medically important snakes. Does anybody have a random question? Everybody comfortable? Everybody awake? we'll see how that goes during the day. Bring out a snake, yeah. Kate, yeah.
All right, thank you very much. Carrie, are you ready with your soon? All right, so we're going to talk about the most significant venomous snakes here in Eswatini. We are going to use the following terms often. Please just make a note in your notepad. We've got a beautiful notepad. You're going to have to refer to this throughout the day. We've got snakes with neurotoxic venom. They cause progressive weakness. So you become progressively weaker and weaker as the venom takes effect. It is called progressive weakness, PW syndrome. The snakes that are responsible for this, the neurotoxic envenomation, is the black mamba. We do not have the green mamba in Eswatini, as well as the snouted cobra. The cytotoxic venom is venom that destroys tissue. It's called painful because it's extremely painful. It's progressive. It gets progressively more and more swollen. Okay, so it's called painful progressive swelling, PPS syndrome. Last but not least is the hemotoxic snakes that we have here. The snakes that are cytotoxic, Mozambique spitting cobra, puff adder, and rinkles. The snouted cobra sneaks in there a little bit. It's a very sneaky snake when you are trying to treat it because it presents as cytotoxic and then it turns neurotoxic. But Dr. Christoph will cover that in detail. Our hemotoxic snakes, they cause bleeding syndrome, so it's uncontrolled bleeding. And we've got the boomslang, responsible for bleeding syndrome. Antivenom is effective for all these snakes. Okay? Then we've got not effective, neurotoxic, is the shield nose snake as well as the berg adder. Cytotoxic is stiletto snake, night adder, snouted night adder. Then we've got the hemotoxic snake. This is the vine snake. Very common, bites very uncommon, so there's no medical treatment for this particular species. Okay, it's prayer, get your will in order, and phone Dr. Christoph or Dr. Hugo fast. All right. This is neurotoxic venom.
This is a sign of mamba bite, this one.
Sorry?
A mouse was doing this. Was he playing in the bush? It was not playing in the bush. Not on the fish.
It's not playing on the screen, I don't know why. Okay, start it again, please. Go back. This one.
Do you want to talk about it first before you play?
No.
It's in.
So we're not going to talk about the medical management at this stage. That's Christoph's job.
It's a sign of mamba.
But this is very typical. You get fasciculations,
Was he playing?
the muscles twitch, okay? Excessive secretions, weakness. This is very typical, okay? So you can see the weakness. They can't open their eyes. They can't speak. They sweat a lot. They struggle to breathe. Neurotoxic, you're basically suffering to death on dry land. You're drowning, but there's no water involved. Okay. This is another video I'd like to show you. This was after 4 vials of antivenom.
Okay.
She was in a very remote area with no life support. But the antivenom is starting to kick in.
Okay.
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 Cytotoxic venom. The biggest problem that we have in Eswatini is cytotoxic venom. 80% of our bites are caused by these snakes. They cause horrendous tissue damage. This is a very good example of what happens if you get bitten by Mozambique spitting cobra or puff adder. The first aid here is critical. If you apply the incorrect first aid with a Mozambique spitting cobra or a puff adder, this is what it's going to look like. Okay, so today in the general awareness course, as well in the medical management, Chris will be covering the basic first aid. Okay, cytotoxic venom, think battery acid. Causes tissue damage, very seldom causes death, unless it's totally neglected. Hemotoxic venom, the one that causes bleeding, it causes uncontrolled bleeding. Without antivenom, the patient will not survive. This is what you will see. So you will see bleeding at the bite site, then you will see bleeding from every orifice, every last scratch you've had, until you bleed out. Hemotoxic venom. All right, not to be confused, sometimes we have snakes that cause a little bit of bleeding, but you see the swelling. So with the boomslang and the vine snake, there will be no swelling. I shouldn't be talking about this. This is Chris's job. But please don't confuse something like this. If you see swelling and bleeding, it is not a vine snake or a boomslang. It's a puff adder. All right. We need not to only treat the medical emergency of a snake bite. We need to consider the long-term effects. And they include amputations, deformities for the rest of their lives, and in some extreme cases, cancer. A neglected bite can turn into cancer. This is our fourth victim here in Eswatini that's reached out for assistance. It's just come in, and it's because it was a neglected Mozambique spitting cobra bite. All right. On our website, you can take a photograph with your phone that is on silent. On our website, everything that is going to be discussed is on the website. Our snake identification, our medical management, the medical management treatment guideline. We're going to put the symposium. It's being recorded. It will be loaded on our website too. So if you've missed something or there's something that you want to just cover, please go to our website. It's all there. Everybody got a photograph of it? How much for time? Okay, that's good. Okay, so that basically covers what we're going to cover today. Are there any questions so far? You're allowed to ask questions now. Any questions? Please may we see a hand of those who are attending the veterinary session today. Can you please stand? We just need to see numbers. Those that are joining the veterinary section, please stand. Don't be shy. Good Lord. Okay. Those that are joining the general awareness, can you stand, please? General snake awareness. Good Lord. Okay. Thank you. If you can sit down. Those that are here for the medical management of snakebite, can you stand? Medical? Okay, we're good. All right. Okay. Those of you who are from EMS who want to attend the practical session, are you here, the EMS team? I think they're a bit late. There's 20 of them. Well, there's one. EMS, can you stand up? The guys that are here for EMS? Don't be shy. Here we go. You are welcome to move from session to session, group to group. If you want to catch something on that particular topic, feel free to move to that room. Do so quietly, please. Don't have a long conversation. If your phone rings during the symposium, we're going to put it in the mamba cage. Okay? And we're not going to take it out. It's up to you to try and get your phone out of that mamba cage. If you are disrespectful and you're speaking while the panel member is speaking, we're going to put you and your phone into the mamba cage. Okay. All right. Guys, any questions? Okay. Then I think we can move on. We've got a very busy schedule today. The next panel member. Thank you, Chris.
Thank you, Tia. Okay, so we're actually ahead of time, and this is good. I don't think we've ever been ahead of time. No, you...
Sorry, Carrie. God, I haven't gone through the snake ID. Okay, sorry.
Right, cool.
So I took a shortcut. I was a bit busy. 17. Mash?
How many snake people does it take to get a laptop to work?
Too many.
Has everybody who has arrived this morning, do you all have a conference bag? If you do not have a conference bag, please put your hand up. So, it's interesting what Tia was showing now in that first presentation. It's almost like your worst nightmare, do you agree? And I think a good point to sort of summarize what she said there was, don't worry too much about it. You have these heroes in front here, you have the information being passed on to you today, and we have this beautiful Muti. What's this Muti's name?
Red Bull.
Antivenom. If we can get antivenom quick enough, and enough of the antivenom into a snake bite victim, 99% of what you saw on those ghastly pictures there can be avoided. All right. So that's the take-home message today. Yes, it's to freak you out and show you the potential of what these snakes can have on a human body. But I think the point of today is also to show you all that there is a light at the end of the tunnel. And that is what we need to manage here today. We need to take this message further, all right, to the people, to the community, and say, it's okay. We do have a plan. And thanks to Tia, she's got an amazing plan in Swaziland, in Eswatini. All right. Yeah, quiz time. I can sing. Okay, I won't. First person to put their hand up gets a free t-shirt. What is classified, drop for drop, as the most venomous snake that we have in Eswatini? Hands up! Wait, I saw your hand going up first. Stand up, please. Ooh, I put you on the spot. You're going to have to speak in the mic. Drop for drop. LD50, potency-wise, what is the most venomous snake that we have in Eswatini? The answer's going to be...
Black mamba?
No. You have to take your shirt off now. Oh, how does... No, I'm just... I'm sure that you were the... I saw your target on your shirt, yeah. Stand up. Mpumi.
Yeah.
Shy up.
Thank you. I think it's a Mozambican spitting cobra.
Negative. Negative, Mfo. Ish. These guys. But that's why you're here, to learn. You choose, Tia. Choose one. I can't see. Okay, Dr. Ntawani, stand up. Is that you? I don't know who you are, sorry.
Boom slang.
Yebo! Can we have a tea? Oh, there we go. Tia, are you ready? Can I stop giving your stuff away? Boomslang. Boomslang was the answer. Hemotoxin, we can talk in a little bit more detail about that later. Yeah, the boomslang.
Okay, thank you. All right. So the dangerous snakes of Eswatini, there's a poster for you on our website. These are them. We've discovered them. Black mamba, snouted cobra, Mozambique spitting cobra, puff adder, rinkels, boomslang, vine snake, stiletto snake, berg adder, snouted berg. The berg adder, the night adder, the snouted night adder, and the shield-nosed snake, we've only ever found one species. So we're not sure where they are, they're hiding. All right, the first one we're going to cover is the black mamba. We are petrified of the black mamba, correct? There's no reason to be afraid of a black mamba. They are not the monsters we make them out to be. They will always try and run away. I've been catching snakes for 20 years. I've probably caught over 2,000 black mambas. Not once did it chase me. I've always chased the snake. The only time it will bite is out of defense, if you are attacking it, or if you are hurting it, if you accidentally stand on it, or you sit on it. Okay? They're not a snake that looks or seeks to take revenge. They don't move in couples and pairs. All right? They will not come and kill you because you killed the wife. All right? A lot of bites happen because we're trying to kill the snake. Okay? Many people get bitten. They think they are Batman, Superman, and they take a stick or a stone to the snake, and if you hurt that snake, it's going to defend itself. You will not allow anybody to attack you and not defend yourself. Okay, and the snake is exactly the same. It's active during the day. Snake bites at night from a black mamba are very, very rare. We do get them every now and then, but very seldom. The symptoms, we've covered that very quickly. Progressive weakness syndrome, it makes you so weak you can't take a breath of air. Okay? First aid. This will be covered in the snake awareness, the detailed snake awareness course. And I don't care what all these beautiful people say here, okay? I advise you use a tourniquet. You have to use a tourniquet because you're not going to arrive alive at the medical facility without. If you're close to a medical facility, just go. But if you are more than 20 minutes away, you have to apply a tourniquet. Okay? We live in very remote areas. Our facilities with anti-venom and life support are far away. We don't have helicopters that can fly in and come and save us. You're going to have to do this to be able to survive. A tourniquet, if I can ask Hugo to stand up. The tourniquet needs to be applied as high up the bitten limb as possible. So if you get bitten on your hand, you need to tourniquet as high up the bitten limb as possible. If you get bitten on the foot, you need to tourniquet as high as you possibly can up the thigh. Okay. This is the only snake you will do this for. The black mamba, if you are 100% sure you've been bitten by a black mamba, you will tourniquet. If you don't know what it is, don't think the worst and apply a tourniquet, go to a medical facility. So if you are 100% you've been nabbed by a black mamba, tourniquet, call for help and get to a medical facility. Yeah? We good? We've also got these very quick IDs. How do we ID a black mamba? One, it's not black. The name comes from the inside of the mouth. The mouth is black. So that's where the name comes from. It's a grey snake with a white belly. Coffin-shaped head and very long. They grow up to 2 meters in 1 year. So they grow very long and then they start getting fatter and fatter as they get older. Okay, grey snake, long-shaped head, coffin-shaped head, black mouth inside, white tummy. The snouted cobra. This is a snake we don't respect enough in this country. We see a lot of snouted cobra bites. They are active during the day. They're a big snake. They're a beautiful golden color. They make a big hood on their throat. They've got a broad band. Okay, their venom is highly neurotoxic, but it plays with you. It starts off as cytotoxic. You think you've got a cytotoxic bite, and then 4 hours later, 16 hours later, or 24 hours later, the patient starts to have difficulty breathing. That's when the neurotoxic effect takes effect. Okay? So be very careful, the medical people here today. Snouted cobra presents as cytotoxic, then becomes neurotoxic. Symptoms, what does it feel like when it bites you? It's painful, not very painful. There is minimal swelling or mild swelling. You gag. One of the first symptoms you have with a snouted cobra is the pain and swelling, and then after a couple of hours you'll start to gag. You'll sweat, you'll have difficulty breathing, and if you don't have antivenom or a ventilator, you will stop breathing. Snouted cobra. Very common in the low veld area, not found up here in the high veld. So it's a low veld snake. In Siswati, we call it the Pembentwan. Don't laugh at how I pronounce it. Okay, so how do we recognize this snake? It is a beautiful, don't laugh at me, Bongi. I'll get you tonight, didn't I? I've been trying for 20 years. Okay, so it's a big, robust, big-bodied snake. They can get quite long, beautiful honey-colored body. On the throat, a broad band, honey-colored band. The Mozambique spitting cobra, Mfeti, our biggest problem in Eswatini. We get a lot of snake bites from this particular species. The treatment is very difficult. It doesn't matter how hard we try, there's usually some necrosis, and if there was a tourniquet or no antivenom, the effects are horrific. Really difficult. The surgeons have got to get involved. This snake is a vacuum cleaner. Oh, God. The snake is a vacuum cleaner. It eats everything. It will go into your home. It will investigate. It will go into your kitchen. It will look around, go into your shoes, and then it will climb onto your bed. Okay? And on your bed, anything that moves, it will bite. So if it twitches, it will bite to see if it's edible. So many of our bites are at night when people are sleeping. So if I may ask each and every gentleman in this room today, Valentine's Day, don't buy flowers, buy a mosquito net. Cover your bed with a mosquito net. You don't need flowers. Okay, you need to protect yourself. What does it feel like when it bites you? Pain beyond belief. Throbbing, swelling, pain. You can't think, was I possibly bitten by a snake? You will know. Okay, there'll be no doubt in your mind. Mozambique spitting cobra. It's brown, uniform color, brown. The skin is black. So if you look really closely, you'll see that the skin between the scales is black. Easy way to identify it. One of the best ways is your eyes are going to be burning because it spat you in the face. Okay, then you know it's a Mozambique spitting cobra. It's got a salmon-colored band on the throat. Found throughout Eswatini. The other snake we have, the cytotoxic snake, is the puff adder, the libululu. We all know this snake in Eswatini. Okay, cytotoxic, very painful. It's active during the day and at night, mostly at night. Most of the snake bites happen at dusk and dawn. Bites are below the knee, usually, or to the hand if they've been reaching somewhere and they've been bitten on the hand. Because it's a short snake, the bites are usually below the knee. Okay, what does it feel like? Incredibly painful. All right? This is how you ID it. Oh gosh. Okay. It's got chevrons, these V marks that point towards the tail. Very rough looking snake, broad head, very distinct from the neck. Best way to identify this one is by those chevron, those cream colored marks that move towards or point towards the tail. All right, Rinkels is found here in the Highveld. Black, beautiful snake. Our Rinkels has beautiful bands. It's got a black, shiny throat with white stripes. I'm talking really fast because I'm scared of Chris and TikTok. But this information is in the books that you have, and it's on our website. So please have a look at it in detail. So it's got a shiny black throat with white bands. Very few bites from the snake, actually only one in 20 years. All right. Boomslang, this is the snake that Chris said to you, drop for drop is the most venomous snake in Eswatini. We've had a couple, 6 or 7 in 20 years. They're very shy, they don't bite often. They are not a green mamba, for heaven's sakes. The males are green and long, the females are brown and long. The only species we have that you can differentiate the sex sort of by the color. It lives in trees. Our dogs are most affected by this snake, humans very seldom. All right, so the head shape, it looks like a VW beetle, not like a long coffin shape of a mamba. This is not a green mamba. I see that gentleman wants to argue with me. All right. The Lunungu, very shy snake, never had a bite here in Eswatini, one dry bite. This is the snake that has no treatment. It lives in trees, very seldom comes down from trees. Beautiful snake. If you see it in your garden, leave it there. It's not going to hurt you or your dog or anybody else. It's not interested in you. You're not a bird or a lizard. You're quite fine. Okay. The berg adder, I'd love to find one. Okay, so we don't really have to worry about this one. Nor the shield-nosed snake. We've only ever found one dead species here in Eswatini. They're very shy and they're hiding from us. The stiletto snake, I'd like to talk about the stiletto snake. It's an insignificant little black snake that's shiny. It's got fangs that instead of like the others, like Dracula, that stick out in the front of the mouth, they're actually sideways. So there's no ways you can pick up that snake without getting bitten. It bites a lot of people. Probably 20% of our snake bite victims are from the stiletto snake. There's no antivenom for it. I don't know why. I would personally think it needs to be in here because it bites so many people and the bite is incredibly unpleasant. There are also amputations from this snake, so I do believe we should consider. The night adder, not that serious, hurts like crazy. We don't often see significant necrosis, bleeding. Sometimes you have the odd case, but it's a lovely little snake that eats all the frogs. Bite, like I said, very painful. It's going to hurt for a week or 2, and you're going to be really sorry and drink a lot of whiskey, but you'll be okay. The snouted night adder, his baby brother, exactly the same as the night adder, except it's got a little flat nose. It looks like it's walked into a door. So it's got a flat little nose. We don't often see them very much in Simunya area. We get them often. They're breeding at Simunya Club, and I'm keeping the population going. All right, so I just quickly want to show you the difference between a mamba and a boomslang. This is often a mistake because the female boomslang looks very similar to that of a mamba. Okay, so it's also got a white tummy, so when you're looking up in a tree, it can look like a mamba. And sometimes the color of the snake is grayish. Okay, so look at the head shape. A mamba looks like a hearse. A long coffin shaped. I thought you were bringing TikTok. I got so nervous. Okay, so it's got a long, thank you, Chris. It's got a long coffin-shaped head like a hearse, where the boomslang has a very round head, a big eye. It looks like a VW Beetle. You cannot identify a snake if you're running at 20 kilometers an hour. You don't need to run away from snakes. Stop, take a look, take a photo, send it to us, and we will tell you what it is. This snake I release in my garden, the boomslang, because it really is such a chill snake. They don't bite. They will only bite if you ganga. Don't ganga with a boomslang, and it won't bite you. Okay? The green mamba has got the same sort of head, coffin-shaped, but the male has that very distinct VW head. Okay, I've got 5 minutes left. I'm going to do this. I think that's me, guys. It is. Thank you very much. We do have like 4 minutes. Are there any questions you'd like to ask? I know I'm not allowed to do this, but I've got 4 minutes. Yes, Roxy. Because it takes so much longer to kill you. So it can actually take 16, 24 hours. Okay, so it's not as rapid as that of the black mamba. You've got more than enough time to go to a medical facility. Should I cover that? So the snouted cobra presents as cytotoxic, so it's very, very painful when it bites you. Very painful, it's painful, where the black mamba is not. It starts off with pain and swelling before you start becoming weak, you gag, and then the paralysis sets in. But that's 4 hours, 6 hours, 16 hours later, where the black mamba can take you out within 30 minutes. Okay, so why tourniquet if you've got enough time? If you are on top of the Nlembe mountain, yes, I would consider tourniqueting. But if you are within 2 hours, 3 hours of a medical facility, there's no need. Okay, was there a panel member that wanted to say something? Nick. Oh, Chris. Sorry, ma'am, yes. The Mozambique spitting cobra. Okay, so the Mozambique spitting cobra is a vacuum cleaner. So it eats anything, honestly. If it's possibly edible, it will eat it. So possibly when it is misty and rainy, there are more frogs that are on the road, and then you will see them coming to hunt. But no, they don't prefer cold and wet and misty weather. They just like frogs. Okay. Yeah, sure.
So I'm from South Africa, the Nelspruit region, Lowveld region of South Africa. And our Mozambique spitting cobra is by far every season the most common snake that we catch. I did some stats, November, December, January, just for our area, end of last year, beginning of this year, only 3 months. We caught, and this is only the people on my snake group, this is nothing else. It's the guys that recorded catching a Mozambique spitting cobra and putting it on the group. 78 Mozambique spitting cobras. All right, it's a phenomenal amount of these little land piranhas. They're horrible. All right, you go just up the escarpment up to Machadodorp. As you get into Belfast, no Mozambique spitting cobras. They then swap over to the Rinkel. So as soon as you hit elevation, altitude, it swaps over to a different species. So they do like the more humid, wet type of environments. Yeah.
But we also find them in Mbabane, Bulembu, and all the cooler regions here in Eswatini. How many have we caught? Hundreds. Okay, hundreds. It's our most prolific snake that we have here. One last question if there is? Yes, sir. The python. The python has no venom. It is not a dangerous snake. We've never lost a single individual to a python. It is a big snake. It is a strong snake. It will not attack you. The stories that I was walking in the forest and then all of a sudden this python wrapped around me and it was trying to eat me, so I killed it. He's lying. He was trying to catch the python to sell. Okay, I'm done. All right, pythons are not dangerous. You're going to hold one today, I promise. I'm going to hand over. Thank you very much for listening to me. Thank you.
Okay, morning everyone. Just hold a little bit further from my mouth. I just want to find out, hands up, who is doctors and paramedics here today? Okay, cool. EMS specific? Okay, so I'm here for you. All right, so my talk's going to be about pre-hospital management, paramedic management. We'll do first aid after tea. You guys all got your your flipper cards that look like this from your table? So there's 3 different ones. There's one for the layman, which is first aiders. There's one for the EMS guys, which says emergency care. And there's one for hospital staff. So these cards were developed just to make snake bite management easier. So all you do if you have a snake bite, you open it up and you just follow the instructions. Okay. There is variance from this, but this will be your baseline to treat your patients from. And then if you're not sure about snakes, if you open it up at the back, you'll see there are different snakes at the back with their different distributions throughout Eswatini. Okay, so very cool cards to use. My talk will go on the emergency care flipper card if you want to follow that one. Okay, so they said there's about half a second delay. There we go. There we go. Okay, so common challenges found in the pre-hospital environment is that there's limited formal training. So when we do our paramedic training, universities, private colleges, there is not much focus on snake bite management. It's focused on heart attacks, strokes, burns, airway management, all of that stuff. So the teachings on snake bites is very limited. So we're trying to improve on that. It's outdated practice and misinformation. The people teaching this have been taught rubbish 20, 30 years ago, and they're still teaching the same thing at university. So we are picking up wrong information and then treating patients with what we were taught at university level. There's a fear of lack of interest. People don't like snakes, so they just push it out the door. If something happens, we'll phone a friend. Okay, which is the wrong thing. We'll get to snake bite syndrome management just now. We don't need to know what snake bit you, so don't worry about the snakes. If you cannot look at them, it's fine. Don't need to know what they bit you. Infrequent exposures. As paramedics in South Africa, we don't see a lot of snake bites. We are in Gauteng, but if you're more in an area where you see a lot more snake bites, you're going to know how to treat them better. So lack of experience is a problem, and then underestimation of envenomation severity. You know, you're going to die. You won't die right now. So just put them on the bus, put up a drip. Let's go to hospital. Someone else's problem. Okay, you must understand how quickly things can go south. Is this guy working, or are you doing it manually? Okay, so in Eswatini, they've made the process a lot easier. They have introduced the National Snakebite Management Guidelines, and that we've made these flipper cards, so you can download those national. Well, maybe not too far from the computer that it's not working. Yeah, there we go. I'm standing too far from the computer. Okay, so you guys can download those from the internet. If you Google the National Snakebite Management Guidelines, it'll be the first thing to pop up in Google. And that goes all the way from first aid, pre-hospital management into the hospital. So it's a good guideline to follow. So assessing your patients. Sorry, there's a bit. This thing. Okay, so obviously you're going to sort out scene safety first. If you go into your first card at the top, we're on that part there. So you're going to go over scene safety. Make sure that the snake is out of the way. You don't want more than one person bitten by the snake. So if the snake is in an office environment, remove the patient outside, treat him outside. Don't treat him inside where the snake is. You don't want more person bitten by the snake. Then you'll move on to your circulation, airway, breathing. Assess if there is any life-threatening emergencies at the moment. If there is none, skip. Don't worry about sorting out airways and stuff. If the patient's breathing and the saturation is looking all right, move on to the next thing. We can get back to that later. If there's an issue, we're going to sort it out first before moving on. Then we're going to look at the vital signs, heart rates, blood pressures, saturations, ETCO2, everything that's your capabilities as a pre-hospital practitioner. Look at all the vital signs, get a baseline of everything. We're going to do a physical examination. We look at fang marks. The lack of fang marks does not mean it's not venomous. Fang marks does not mean it was venomous. It's just you can get a guard of maybe how big the snake was. Bigger snakes have bigger venom glands, which will make the situation worse. You can look for signs and symptoms like swelling, bleeding, paralysis, which is your different types of venoms, as well as signs of shock. Okay, so shock is the situation where your brain's not getting enough oxygen, and it's characterized by fast heart rate at the beginning, slower heart rate later, low blood pressure, sweating. So any of those signs or symptoms is severe, and you need to get to a hospital very quickly because your patient's going downhill. You do the sample history. What you're looking for especially is any history of allergies to antivenoms, allergies to snake, when the snake bit them to the venom. Anaphylaxis is a real killer. You can die 15 minutes of anaphylaxis long before the black mamba venom kills you. So that's another danger that comes in with snake bites. So irrespective of species, if you arrive on scene and the tourniquet is in place, please do not remove it. There is a risk of venom rush and all that stuff coming in. So if it's in place, leave it in place. Even if it's the wrong species, they can sort it out at the hospital. Okay, if it's been up for an hour and you remove it, there are dangers that come with that we cannot deal with pre-hospitally. And then for identification, you don't need to know what snake bit you. Just get the patient on the bus, treat the symptoms, make your way to the hospital. This thing is not working. There we go. Sorry about that. Okay, so to make life easier, we do not need to know what snake bit you. Okay, a photograph, a description is great, then we exactly know kind of where we're going with the treatment, but if you don't have it, don't stress. What we do is we work on a syndromic management. So like T has mentioned a bit earlier, I'm going to go a bit more into detail. So your first snake bite syndrome is painful progressive swelling. If you get bitten by those type of snakes, severe pain and swelling of the limb, arm, wherever they bit you. There's immense pain. I will explain. If you're coming next door for the snake awareness and first aid stuff, I will discuss a snake bite where someone was bitten by a rattlesnake and how bad the pain was, just to get an idea. It's really not something to play around with. So please don't be a little bit of pain medication. It's severe pain. The species responsible is your Mozambique spitting cobras, stilettos, and night adders. Yes, puff adders also have this, but puff adders have got a mixture of venom, so we'll get to the puff adders now. So just be careful here of hypovolemic shock because of the swelling and the loss of fluids into the limb area. Let's see if we got it to here. Can you press them because this thing is not working? Cool. Okay, snake bites syndrome 2 is progressive weakness. So this is paralysis, so the patient will slowly go backwards. Starting with eyelids closing up from being paralyzed, difficulty in talking, the tongue's going paralyzed. There will be drooling, secretions, difficulty in breathing. They will start to go unconscious until they end up stopping to breathe and going into cardiac arrest. So this is your black mamba is responsible for this. Yes, the Snyder cobra also has progressive weakness, but that's got a mixture of cytotoxin in it, so we'll get to the mixtures now. Bleeding is the third one. So your boomslang and your vine snake are responsible for the bleeding. So when you get bitten by these snakes, it's a very slow onset of symptoms. They talk about up to 24 to 48 hours after the bite, where sometimes it's a very delayed case. You'll start to bleed around the bite site, where you put up the drip, the IV line site, you start to bleed in the gums, you'll pee blood, poo blood, blood in the brain, severe headaches, and eventually just bleed to death over a period of time. Snakebite 4 is mixed painful progressive swelling and bleeding, so it's a combination of bleeding and swelling. That is your puff adders. The bleeding is not as severe as you see with a boomslang, but you must still expect that there will be bleeding before these bites. And then number 5 is progressive swelling and progressive weakness. So that's your combination of Snyder cobra and your wrinkle. So you'll see both symptoms of swelling and paralysis setting in. Okay, so if you can get your patient, look at the symptoms, and you can classify them into one of the 4 different categories. If it's only bleeding, you'll get monovalent. If it's the other 4, they'll go for the polyvalent. So you see, you don't need to know what snake bit you. Work on the symptoms. Okay, another one. So just a bit on management. Neurotoxins, extreme emergency. So for the EMS pre-hospital, we don't intubate as a preventative measure. We wait until we have to intubate. Okay, so we'll first try and give oxygen if the sats gets low, work with, as it gets less and less, try and use the BVM, and then we'll intubate when necessary. Unless there's a severe cytotoxic bite in the neck area where everything will shut closed, then you'll treat that almost like an airway burn where you'll treat early, but for neurotoxic bites, we won't just intubate because we can. Okay, so your induction, you'll use ketamine. Ketamine is your choice because it's both a analgesic and a induction agent, so you get some ketamine. If your patient's unconscious, just use the ketamine. If he is still semi-conscious, you'll have to use a paralytic, which you use rocuronium. You don't want to use saxathonium. And then you'll manage it with ketamine as a post-intubation sedation. Okay, stay away from the morphine and the dormicum. Ventilator settings are it's in your card. I'm not going to go into it. Dr. Minna will go into ventilation, a whole talk about that, so that's coming up next. I'm not going to cover on that. But your settings is on your card, so you can use that as a reference guide if you have a ventilator to your disposal. Hypertension, so if there is severe swelling from a puff at a bite, you're going to have the fluid loss, which is going to drop your blood pressure. If you have a system where your blood pressure is below 90 and you have a normal pulse still, you're going to do a fluid resuscitation, 1 to 2 liters of fluid, up to 30 mils a kg. 20 mils a kg is for trauma, 30 mils a kg is for your sepsis guidelines, which include your snake bites. Okay, if you have a combination of low blood pressure and a slow heart rate, you can first try atropine, and if that doesn't work, you're going to move on to a adrenaline infusion. Okay, in your guideline also there's an option for using a syringe driver, and there's just using a 200 ml saline. The guidelines are in your flipper card. Okay. Cytotoxic management, pain management is crucial. Okay, so you're first going to start off with something like your paracetamols. If that doesn't work, you can go on to your opioids. Remember that opioids just mimic some of your sinus symptoms, so just watch those. But you want to stay away from your NSAIDs, so your diclofenac, your ibuprofen, that type of medicine you should not be using. And then tranexamic acid is for the guys who don't know, it's a medication we use for bleeding. It doesn't work with bleeding from wormslang because of the way both work, so it's contraindicated in snake bites, so please don't use TXA in snake bites. All right. Another one. Okay, so don't stay and play. Get your patient in the bus, phone ahead, get to the hospital so they can prepare on your way there. Do not remove a tourniquet that's been placed, rather leave it. Accurate identification is not required. You can treat symptomatically, and when in doubt, call the Eswatini Antivenom Foundation. So there's Tia's number. I don't know where she has just confirmed the top one is for snake bites, the bottom one is for snake removals. Yeah, okay, cool. So if you have a snake bite, phone the top one. If you have a snake, phone the bottom one. There's the numbers. Cool. And the last slide is just, if you need my details, there's my details on the board. How are we doing with time? 10.5 minutes this time. Okay, cool. Is there any questions on pre-hospital medicine? Yes.
You said do not move the tourniquet. So I'm just wanted to find out what happens then if you've tourniqueted a wrong snake and you happen to remove it maybe at the wrong time or before you get to a hospital.
Okay, so remember, if you remove a tourniquet very quickly, you can have something called venom rush if it's on for a long time. Okay, so what it means is when a snake bites you, the venom slowly travels through the body and you get a slow onset of symptoms. If you place a tourniquet and you leave it for a long time, the venom makes its way into the lymphatic and the blood system, and you remove it quickly, everything goes through the body at once. Okay, so you can have venom rush and you can have organ failure very quickly. So therefore, we don't remove it pre-hospitally. That is something they can control in the hospital. We want to get a live patient to the hospital. We don't want to get, like Tia said, corpse to the hospital. So that's why if it's in place, leave it. We cannot deal with the consequences before we get to hospital as paramedics. Okay.
There's also a paper published by Prof. Engelbrecht, on how they manage the release of a tourniquet. They replace the tourniquet with a blood pressure cuff, and they pump it up. And then as they're doing, there's a symmetry between the infusion rate of the antivenom and the release of that blood pressure cuff. And they've published papers on that. It's the gospel on how to actually do that safely. Good. Okay. Let's just check here quickly. Hugo, you're up. What do you guys call a sleeping snake? A sleeping snake. A king coma. A king coma. No. Don't worry, I'm here all day. I'm here all day. All right. Ladies and gentlemen, Dr. Hugo.
They're gonna start laughing at your jokes very soon. It's gonna get better. I promise it's gonna get better. All right, so I'm gonna talk. I'm gonna talk about airway management and ventilation in snakebite patients, specifically those with neurotoxic syndrome, and I'm gonna sort of add a few things, and also those people that are not medical people will understand why these patients or end up on a ventilator for a few days and how it works. Okay, so the question, or my topic was given airway management, and so the question would be, why would airway management be different in neurotoxic patients? It should actually be, why would you manage the neurotoxic snake bite, airway, and breathing differently? So our book that we use for emergency medicine, Rosens and Tintinelli, both of them refer to these patients should be monitored specifically and individually. So a neurotoxic bite is not the patient that you give to the porter or the enrolled nurse to say, just pop in there every few minutes, check if the patient is still okay, because this thing can creep onto you where the patient stops breathing, and then you've got a problem. So these patients need to be in a high care sort of setting, and you need to have this patient on good monitoring. So that is why it is slightly different, and our decision to intubate is also going to be different for neurotoxic patients with neurotoxic syndrome. I say neurotoxic syndrome because some snakes do I'm not only talking about the mamba, there are some snakes with cross venoms, so they have got cytotoxic and neurotoxic venom, and in different areas they might have a more cytotoxic effect, and in some areas they might have a more neurotoxic effect. I'm not sure that your local snouted, how the distribution of the venom is here, I don't know. But she's not here now. Yeah. Okay, so how do we monitor for airway? How do we monitor for airway, breathing and deterioration after antivenom administration when the patient arrives? So the first thing that I do, and this is from a lot of articles, is monitoring of the patient's CO2. So CO2 for me, the exhaled CO2 is sort of the gold standard of monitoring for these patients. Why? Because we can see if the patient's breathing becomes worse. So the slower you breathe, the shallower you breathe, the higher the CO2 is going to get that you breathe out. So you definitely need some sort of monitor, and we use nasal CO2 monitoring on all our monitors in the emergency unit, in ICU, and on the ambulances to monitor the exhaled CO2. If patients are intubated, you can do it with the end-tidal CO2 as well. You can modify, I've heard yesterday from Dr. I forgot his name, he met too many people, but they can modify the ones in the anesthesia machine here to sort of use as a nasal cannula CO2 monitoring. Yes. So that is nice if you don't have one, but I consider that to be the gold standard, because saturation will drop at the later stage when the patient has stopped breathing. Then the saturation will drop. So saturation is sort of low on the list to monitor. Then we've got this weakness that the patient develops, ptosis, the eyes that hangs. For me, that's not a big sign. We've got patients that's fully awake, but they just can't open their eyes. So it's not necessary to intubate those patients. You'll see that if you give them antivenom, the ones that doesn't need to be intubated, they will later start opening their eyes. So that's a bad indicator. But the progressive weakness from the top downwards, that is a problem. Okay, so once and also the speed of that deterioration. When the patient has got difficulty breathing, they can't swallow anymore, and they start drooling, big problem. Okay, so when they stop swallowing, that is when you need to be ready to intubate. Dysphonia is when when they talk and you can't hear what they are saying. So, like, what does this sound to you? A drunk person. So these patients present like a person that has taken too many alcohol. Okay, so that's sometimes how they are perceived, and mistakes have been made. They actually made mistakes in sending these patients home and said, no, they're drunk. And the reason for that is because they had alcohol, and then they're very, very tough, and then they're going to catch the snake. Okay, so the alcohol will make them trying to catch the snake. Okay, and then they come in and they had a lot of alcohol, so then they smell like alcohol, and you think, okay, just a scratch of a twig or something, and then it was a bite actually. So never just say the person's drunk. Same with a stroke. It looks very much like a stroke as well. Then once the patient's acidotic, so you definitely need to do blood gases on these patients on admission, and then at least every half an hour. Once this patient is acidotic, and they will become respiratory acidosis, once they're there, you're in trouble. Okay, so then they will develop compensation for that, and that's when they develop renal failure as well. So that is why you need to get these patients before they become acidotic. Okay, it's a very fine line. And then these patients need full monitoring, so it's basically full ICU monitoring from pre-hospital right up to ICU. They need to be on ECG, SpO2, end-tidal CO2 or nasal cannula CO2. We put arterial line and a CVP for all of them, so as to monitor everything intensely. Then, so what now? Because I've given you a lot of things, and so what do we use as a sort of ruler of when to now consider to intubate the patient? So we know that giving the antivenom will not stop the patient from actually having the problem. It will slow it down, and it will make the outcome of the patient much, much better. If there wasn't antivenom, patients would have just died. We would have admitted them in ICU, and they would have died. With the consent of the patient, just for interesting sake, it was a case that happened in Pretoria. I didn't even give my my, what do you call it, disclaimer or whatever. But everything I know I actually learned from Arno. So if you have a question, you can actually ask him. Since I was 12 years old or somewhere there, I started learning from him. And I teach at the University of Pretoria, and I'm director at Critical Care and Emergency Service, so I've got no conflicting things. Okay, so this patient actually is a snake handler. She was called to catch a snake in an informal settlement. Snake was in the car's engine. When she got there, it was identified as a mamba. And I don't know how the process happened, but mamba then bit her. And she phoned Arno and said, okay, I've been bitten by a mamba. And he gave very good advice. He says, just get in your car, you've got 15 minutes. Okay. So she drove to us. We were the closest hospital. he notified the hospital, and we only had 4 vials at that stage, so the ambulances went to other hospitals close by, got antivenom. As she pulled in with her car into the emergency department and we opened the door, she fell out and had complete respiratory arrest. She was intubated there and got antivenom, was 4 days in ICU. Interesting thing is she went into renal failure very quickly. We dialyzed her the same night, no urine output, and the weird symptoms that I haven't seen, like sweating, like when I put up her CVP, when I cleaned, it's dry, and then big sweat drops comes through the skin everywhere. So, but she didn't have any fasciculations, for interesting sake. And she was 4 days in ICU. After the first day, we could put her on CPAP and extubated her on the 3rd day. And she was another 2 days in the ward or in ICU, eye care, and then she went home and she made a full recovery. Without antivenom, she would have stayed in ICU for about 4 to 8 weeks with multi-organ failure. And the other thing is, without proper airway management, she would have been dead. If there was nobody been able to manage the airway, intubate or put in an iGel or a LMA, she would have been dead. Okay. So what I've done is I've taken all these articles, and this is not a good slide. It's there for you to take a picture, but it will be on the website afterwards. These are about 4 articles that we use, that I use to make a little mnemonic, and 2 of them have got South African, or a lot of them are from South African. Prof. Hardcastle, who you'll meet later on, was the main person in the SAS guidelines. So I took that and put it into a mnemonic, which is coming up now. I'm not going to read that but it sort of ties in with this. Common sense, and I'm going to read it. Common sense is not a gift, it's a punishment, because you have to deal with the people around you that does not have common sense. So actually, the decision to put the patient on a ventilator and intubate is a eyeball test. It's something that I didn't sort of say, but it's an eyeball test. When you've got a lot of experience, you will know this patient needs to be intubated. Christoph will walk into the room with a mamba bite and say, this one needs to be intubated. Doesn't need to look at these things. So I think it's an eyeball test at the end of the day, but in the beginning, use something. So if a patient's in ventilatory failure, meaning they're breathing less than 10 times per minute, this is a good idea. If they've got paradoxical breathing, so the stomach is doing this and the chest is doing this, with like a seesaw breathing, that is sort of an indication to start thinking about intubation and ventilation. Elevated CO2s, if you use nasal cannula CO2, sort of above 50, and if you use PA CO2, about 55. Then you will start thinking about that. When the patient doesn't have a gag reflex, you should have already actually started with advanced airway management. If you don't have advanced airway management, then opening the airway, doing suctioning and doing ventilation, mouth-to-mouth ventilation, if you don't have an ambu bag, can actually keep the patient alive until there is someone to be able to intubate or give antivenom to the patient. That's what they did in the Second World War. They did mouth-to-mouth ventilation on these patients for a long time. Tidal volume, so shallow breathing, that will increase the EtCO2, and then the saturation drops, which is the late sign, and I think we should intubate the patient before that happens. So why could intubating these patients be a problem? The answer is very easy. We don't know if they've eaten. So if we try to intubate them, they might vomit. And I'm keeping breaking things. They might vomit and that will go into the airway. And then you've got 2 problems. You've got a snake bite and aspiration pneumonia. So they are probably not starved. So you need to be able to do a rapid sequence induction. So hopefully, not hopefully, but I mean, if the patient is envenomated properly with the neurotoxic venom, you don't have to give a paralytic. If you do have to give a paralytic, you give rocuronium, like Nick said, and then you also need to sedate this patient. So you use the induction dose for ketamine. So it's 1 to 2 milligrams per kg. Remember, that will be the patient won't be breathing, he will look like he's dead, but he is awake inside. You all catch what I'm saying? He's not breathing, he's not moving, he's not looking around, he can hear and feel everything. Okay, so it's like a horror movie basically. So you need to give these patients induction, something for pain and something for sedation. And ketamine is a good combination for that. Paramedics here unfortunately only got Dormicum and morphine. And when I do the session with you guys, I will discuss, we're going to use that because that's all that you've got, but we're going to have to give the patient vasopressors as well, okay, because we're going to drop the BP. But it's criminal to sort of do this to a patient without giving them sedation and pain medication. And they've got poor reserves when they've got this. So when you bag them, the SATS is good, and you take the ambu bag away, the SATS will fall rapidly. So have all your stuff ready. For that we use a lot of mnemonics. There's so many mnemonics. I use the Stop IC bars. It's just to ensure that everything is ready for intubation. So this is a combination of all the Stop IC bars, things that they are available. So suction is the first thing. Need a suction because there'll be a lot of secretions. And you can give something to clear up the secretions. Some people have tried glycopyrrolate for neurotoxic envenomation in any way. So you can give that to try and clear up secretions. Your tubes and tools must be ready. A laryngoscope, ideally a video laryngoscope, so that you're in the first time. And all the other nice stuff like the bougies and the introducers, and I'll show you when we do the airway session. Oxygenation, I normally put the patient on high flow nasal oxygen. So if you don't have the machine that can give 60 liters per minute 100%, then you can take a nasal cannula, connect it to your oxygen and open it to 10 to 15 liters per minute. The next thing that's going to happen is going to pop off the wall. So you need to make a contraption to keep it to the wall. But high flow nasal then with an extra polymask on the face will give the patient optimal oxygenation before you intubate. And then positioning of the patient, we like to put them in the Boo-Hair position, which stands for bed up, head elevated. It's 30 degrees elevation. And also make sure that you've got your pharmacology ready. So mainly, if you can, only ketamine. But if you have to do RSI, ketamine and rocuronium. You can reverse the rocuronium if you've got Sugamadex. You can just reverse that. And obviously these patients, we want them awake and out of the bed as soon as possible. While this is going on, antivenom needs to be going in. That is one of the big things here. Okay, something happened to this slide. IV access, you need IV access for hospital people. You can put up one line because there's a bit of more control. For the pre-hospital people, put up 2 IV lines. One in the left arm, one in the right arm. So one is for if you have to give fluids and inotropes, you sort of don't want to give it in the same line. And when they're at the hospital, they can start giving the antivenom quicker if you've got 2 lines up. So you will put up 2 lines, and also you can do intraosseous infusion. So if you don't get a line up, you put a line in the leg, in the bone, with a bone drill. Can you give antivenom through it? Doctors, yeah? No, yes, paramedics, doctors, can you give antivenom through intraosseous? Yes, you can. You can give everything through intraosseous that you can give IV except TPN. it's feeding. Okay. Then confirmation devices will be your stethoscope, and the gold standard is your ETCO2. And the backup plan, always have a backup plan. So my backup plan is a supraglottic airway device like an iGel or a LMA. If that doesn't work, I can't intubate, can't ventilate, you have to be able to do a surgical cricothyroidotomy. So importantly, also if it's not in your scope to intubate, but you've got iGels, you don't have to hold it back to the patient's face the whole time. Put in an iGel and then ventilate the patient the whole time. So I don't know what happened to the rest of the slides. But post-intubation, this is a plan. You have to have some sort of plan with the patient, especially if you're keeping the patient at your facility. You must have a plan. So you need good monitoring of the patient, and you put the patient on a ventilator. So ideally, if you have a blood gas, you can set the ventilator according to the blood gas. If they're already in acidosis, respiratory acidosis, you're going to want to sort of just manipulate the ventilation so that the respiratory acidosis will go away. That means that we're going to give them what? What changes CO2? Doctors? What can we manipulate on a ventilator to change CO2? There's two main things. Respiratory rate and tidal volume. Those are the two things. There's one other thing that you can do, but we're not going to mention that. It makes it more difficult, but those are the two things. So you're going to manipulate that in order to correct the acidosis, and from there on you can put them on normal physiological ventilation. So the easiest way is do basic ventilation. What you know, give him that. Okay. So if it's SIMV, volume SIMV, use volume SIMV. If you know pressure SIMV, use pressure SIMV. Work out the volume that you want to use, plus minus 7 moles per kg, and make sure that you have a FiO2 ratio of more than 200. So start on 100% oxygen and then quickly wean down. You do not want this patient on high oxygen for long because you want to get them out of ICU. And then start on a PEEP of 5. So there's two things that can change oxygenation. If you've got bad gases, you can then either change the FiO2 or change the PEEP, bring up the PEEP. But remember to blood gases after you do any changes on the ventilation. Make sure to sedate them, give them proper pain medication, start maintenance fluids, thrombophylaxis, also prophylaxis, and vasopressors. Give them adrenaline infusion if they're hypertensive. And in your flipper, I think, or in the guidelines, I have got something called Fast Hugs BID. That is a mnemonic for something that we do every day for all the ICU patients. For the time that you look after the patient, you're going to do Fast Hugs BID on the patient every day. And then normally you can sort of wean them the next day. Okay. Just make sure that to watch the kidneys in these patients, the patients with neurotoxic envenomation. And then something that people don't consider is with every snake bite there's massive cytokine release. Okay, so you can develop ARDS. Okay, so we call it biotrauma to the lungs. So that you can develop a lung problem where you need advanced ventilation for those patients, and especially when it's been delayed, the administration of antivenom. So watch them for ARDS and other sorts of lung trauma. Okay, so how to wean from the ventilator? As soon as the patient's rapid shallow breathing index, and that is a little equation that we do, we take the PaO2 and we divide it by the FiO2, and the FiO2 must be, let's say the patient is on 0.4 oxygen and the PaO2 is 80, then the FiO2, the PF ratio is, no, I'm talking about the PF ratio now. The rapid shallow breathing index, you also work it out like that, and it must be above 200, the PF ratio must be above 200, and the rapid shallow breathing index must be less than 105. To do that, you put the patient on a PEEP of 5, and you put him on a rate of 8 with 40% oxygen and see what happens. Okay. So it's a trial that we do. A lot of ventilators does it on their own. It will give you a rapid shallow breathing index every day. And then you just do this calculation, and if it's less than 105, you know that we can continue weaning the patient. Okay. Then obviously the patient needs full monitoring, and then just for interesting sake, and then switch them to CPAP as soon as you can, so that they can breathe on their own. Okay. Once they can breathe on their own, for 24 hours, take the tube out, get the patient out of the bed. Okay. Then on this side, where there's a picture of me, can you move that quickly? This is just the amount of, or just for statistics wise, how many patient develops complications. So 10% complicate to renal failure. So monitor the urine output, and this is in neurotoxic patients. I'm not talking about cytotoxic. A lot of them have got a lot of those cytotoxic have got renal problems. 20% complicate to ARDS or renal or some sort of lung problems. 10% requires prolonged ventilation. So those that didn't receive antivenom or they got there too late, they will need a tracheostomy and normally a hospital stay of more than 4 weeks. And that's not only neurotoxic venom. So when you've got a cytotoxic bite, a puff adder, and wasn't treated properly, the patient becomes septic. Then septic shock, they might need ventilation because they will get ARDS from septic shock. So I can't remember what I've put there. So, but it was something interesting. So, say again. Yeah, so this is how to take the patient off the ventilator. So essentially, this is quite easy. This is easy to manage the mamba bites. It's basically you have to just support the ventilation and the breathing until the patient recovers, until the antivenom works. And the patient will be fine. Okay. And obviously your nursing care should be excellent. Okay. You must be able to, you must have nursing staff that can turn the patient, make sure there's no pressure sores, that sort of things. So excellent nursing care. The nurses is the most important in these patients actually, is so that they don't walk out with pressure sores and things like that, and they develop, oh yeah, now I remember. Okay, so the average ventilation days is about 4 days. Patient that has got envenomated with in ICU with antivenom, and the ICU stays about 8 days. Hospital stays about 10 days if you include some rehabilitation as well. So, but that's if they received antivenom. If they don't receive antivenom, this can be a very, very, very long road. Okay. Okay.
Thank you very much. So we're doing very well for time, so I think we're going to... Antia's not here, so she can't shout at me. Has anybody got a question? I know Arne's got one. Yeah.
Okay. Higu, come, get up. If you're going to put the antivenom in IO, do you put it in at the same rate as what you would for IV? So we're looking at 400 mils per hour, and you still put 200 mils at a time? And it'll absorb it without a problem. Okay, yes, cool. Thanks.
So having an IO in is exactly like having a CVP in. It's immediately in the system. So it's just, you have to give it under pressure. It will not drop in by itself. So you have to use a pressure bag, and then you have to count your drops. So in an IO, it doesn't drop. So put it on a pressure bag, or put a BP cuff around it, and then blow it up.
Thank you, Doc. Good morning, ladies and gentlemen. I am Praise Chigwanda, and I'm going to be presenting on snakebite care response, case studies of collaborative care to save snakebite victims. And so I am from the Look Commission, and most of this work is definitely in collaboration with the Eswatini Anti-Venom Foundation. So we can find some of this data on the internet. It's generally the burden of snake bites worldwide. Most affected areas are Southeast Asia, India leading, and as well as Sub-Saharan Africa following through. Eswatini is there, South Africa, Gabon, we have Chad, and those other countries up there in Central Africa. So the issue is, like some said earlier on, it is a neglected issue, and so WHO is pushing so that we cover this, and collaborative care now is one aspect of the issue that helps us to achieve the best results we can for this problem. And so it aims at improving survival rates and reducing complication during using multidisciplinary approaches. And so in Eswatini, these are some of the statistics that I got. We around 460 snake bites in the years 2019, 2021, and we had a drop to about 334 in 2022, and then 2023 and 2024 we had 545 and 534 bites. This is from the Ministry of Health, and so far this year we have 136 bites as of let's say last week, because this week's data is yet to go into Ministry of Health and then be recorded. Now, it is known that most of our bites, some will show you graphs later on, that they are highest during the summer months, October to around March. That's where we get most of our bites. And literally anyway in Eswatini, you will get people getting bitten. It's not specific to high-veiled or low-veiled areas, just maybe some differences in the types of snakes, but you will get snake bites around. And then we had summer season of 2023 to 2024, we had 0 bites, which was a very good achievement for the nation. And 0 snake bite related deaths, sorry, not 0 bites, 0 snake bite related deaths. And looking at this, we have this map of Eswatini, and the significance of this was so that we just take a look and see. There's going to be about 3 major hospitals in the country, and they are kind of centrally located. We have Mbabane Government Hospital here in Mbabane. We have Raleigh Fitkin Memorial Hospital in RIFM. I think we also have Manzini HDU at Manzini Government Hospital. And then we have the Luke Commission. And the Luke Commission is one that has been dealing with snake bites, especially complex cases. Even the other 2-3 hospitals, they refer back to us. They refer to us for management of advanced issues when it comes to snake bites. And so as you can see, the map is showing that bites are occurring at remote areas, really, all corners of the nation. And this is statistics at the Luke Commission for the foundation years from about 2020 to 2024, showing clinical outcomes and showing number of bites versus those we gave antivenom to. So the team here is going to emphasize care for those patients who are envenomated, those who receive antivenom from snake bites. But you also have to note that not everybody who gets envenomated needs antivenom, and not everybody who gets bitten by a snake has been envenomated. So we received snake bites, but of, let's say last year, we received about 420, and only 42 of them ever needed antivenom. Some were envenomated, more than 42, and some were not even envenomated, we just monitored. And so collaboration now, it means coordination between healthcare professionals to deliver comprehensive snakebite management, and we have various levels of coordination that is needed. Pre-hospital, we had someone presented on that, how to deal with pre-hospital care for snake bites, and we also have hospital, we heard about airway management here, and we also need specialists in those hospitals as well if there are complications, and we also need rehabilitation teams if there is any disability that is ensuing post snake bite, and we also have public health needed in the equation so that we can improve the knowledge of snake bites, of snakes and snake bites in our population. I do love the concept of teaching the very young generation out there on how to handle snakes and maybe debunk most of the mysteries that are out there, the superstition that is there around snake bites. And so, case number one that I'll talk about today, you will note I'm not going to specifically mention the facilities they passed through. They ended up at the Luke Commission, but there is one case that is not so good, so I'll just mention the region of the nation they're from. This one was from Shiselweni, and that was February 2021, and at that time, the child was 8 years old and was bitten by a black mamba. There was quite a rapid response to the bite, and in about 1 hour, 30 minutes, within the time it was 1 hour, 30 minutes, they had contacted Thea, and Thea contacted Luke Commission, and Luke Commission was asked to meet the patient halfway with an ambulance that was equipped with a doctor, 2 nurses, and an additional staff member to help with supply chain in there. And so the ambulance went out, and the child was actually deteriorating fast, needed to be intubated by the roadside before continuing when they had come across. So that helped, because if they had arrived on their own in whatever car they were using, probably would have gotten to those serious stages that Dr. Hugo was talking about, where it's almost difficult to bring them back. And that was where we saw collaborative work helping a patient. And this child, I think is about 13 years old now, is doing very well to date. He had a full recovery. And we didn't learn that quick response to some of these bites, especially mamba bites. They can kill in very short time, 15 minutes, 30 minutes, 1 hour. So quick responses are very vital to save these lives. The second case is one of another pretty recent, in December. This was a trained snake handler who works with the Eswatini Anti-Venom Foundation. So he was going to catch a black mamba, and when he was trying to catch it, he got bit. And so right away he phoned Thea and told her that I've been bitten and it's a black mamba bite. And Thea called us, and she asked for the same setup, an ambulance with a doctor to come and meet her, because she's the one who drove to find him and then started driving towards us. And yes, she covered quite a lot of distance in a very short period of time. We met them along the way in Manzini, and this gentleman made it. He didn't even need to be intubated throughout. He did have symptoms, but we quickly attended to him. Antivenom was administered in hospital, and he had a full recovery. We were getting, you see, collaboration pre-hospital really matters a lot. Even if the hospitals are equipped, the question is, are we going to get these patients to the right assistance in time? And then the third case is the one that's a bit sad. One of my first cases that I had to go and fetch when I came to Eswatini, 48-year-old woman from Shiselweni region. She was bitten around 3 p.m. and then she presented to a facility, I think within about 30 minutes, and someone had killed the snake, if I'm correct, and so they had photos and they could identify what snake it was. And so I think there was someone, I don't know if it was a snake handler, but they did manage to say it was a black mamba. But I think the facility was not convinced where she presented first, and then she started having neurotoxic symptoms, and then there wasn't even any suspicion that she could be drunk, but so this progressed, and it so happens I think the doctor was not in the facility for some time, and the nurses were the ones who were witnessing this, and then they called, took more time, and it was a total of about 3 hours from the time she was bitten to the time, let's say, Thea was alerted. And then from the time Thea was alerted, we were alerted, and we took about 1 hour for us to then meet them along the way. And at the time we met her, she was being transported on her back. Sadly, if someone is struggling to breathe and having problems, they should never be transported on their back. But she was on her back. She had aspirated so heavily that her saturations were so poor, and I'm sure she now had severe respiratory acidosis. We didn't test it at the time, but in the ambulance we did put a tube in, and we started heading back to the hospital. Unfortunately, she had cardiac arrest en route, and we were not so equipped to be running a cord in an ambulance for over 30 minutes. And so as we got to the hospital, she was unfortunately gone. And then that's where we realized that identification, early identification, if we have the team of snake handlers that the Eswatini Venom Foundation is helping these volunteers out there, they can help with identifying snakes, but also symptoms identification at local facilities, primary facilities where people report to initially. If they are able to see this and attend to it quickly, it helps a lot, and that's where collaborative care comes in, and people are equipped well. And also, the other lesson we got from this was that we really need healthcare practitioners in those primary care facilities who have the skills to manage an advanced airway, at least to intubate. So I did give a challenge to some yesterday saying, if you are a medical doctor and you're here working in a primary care facility, you do need to know how to intubate. It's a basic skill of emergency care that you should be able to do. It saves lives. And so key elements of collaborative care that we need to find, that we find, we have the pre-hospital, we have the hospital, we have the specialist care, and we have the review of cases. So patients will need review after care in the hospital. Some might have disability if things were not attended to in time, and so you need other departments to come in and chip in. And so we all need to collaborate so that we can save lives. Then we can also use telemedicine. Use of WhatsApp, use of calling. We have numbers that were being flighted here. You can always call if you are in doubt of anything, or if you have come across a bite. It helps. The earliest, the better. And any challenges that we might say are being faced in Southern Africa, Eswatini as well, antivenom availability, we do have it in here, but we will be hearing talks about how we also continue to need more sources of antivenom, not just one particular source of antivenom. So we need that to also continue to improve, and we have delayed presentation in remote areas. So education to everybody will help, at least people to know, if I'm in a remote area and I'm bitten, what do I need to do? How do I get to the facilities the fastest possible way? So it's all about education, because almost everywhere people can still get to hospitals within 2 to 3 hours in Eswatini. I believe so, because there aren't large distances too much. Of course, there might be bad roads somewhere, but still, I believe in about 3 hours or so, most people should be able to arrive at a facility that can help them. And so we need also to strengthen the referral systems, caregivers, healthcare givers, knowing and recognizing problematic issues, complex things in these bite victims early, and referring where necessary to make sure that if you're not capable of handling something about a snake bite, you hand over to those who can take over and do a better job. And also, like we mentioned, the antivenom supply chains. I realize some primary care facilities are now getting antivenom, such that by the time some patients arrive at the Luke Commission, I think in the past few months, we actually hear that this one has received 4 vials of antivenom, this one we gave 8 vials of antivenom, and what we just do now is monitoring to make sure there's no sequelae and there's other multidisciplinary teams involved in the care of this patient. Education programs, they do help so that we make sure our population, our community is aware of this. And so collaboration does save lives, and we need to always be timely, we need to be coordinated, we need to standardize our protocols and make sure we save every life we can, except for those lives we know. We were told about the vine snake, I think, where there's no antivenom, maybe, but of the rest of these snakes, we should not be losing lives as our goal as a nation. So let us collaborate and let us partner to serve and to save every last one. Thank you for your attention. Okay, maybe I missed something. Just also a module that helps other facilities that are in here. It's always good to have a senior team of practitioners that collaborates together, not just one person being responsible over a group of people, but maybe 2-3 people being seniors, collaborating together to manage situations, manage patients. It always helps so that nothing is missed. So that's also a point to do with collaborative care that we can implement.
Hugo, do you want to add to that again, like you did yesterday? I think that was a nice sort of driving point.
Yeah, so what I noticed in this whole talk was that there is a team of people that can be called to oversee the junior people, and that's first world medicine. So I travel a lot and I see everywhere in the world, even the good people have got someone that can oversee them. So they've got a group, or they ask a group of senior doctors, and one of them is available, at least one of them, for them to call 24/7. So whenever there's a doctor at a facility, and I think it should extend to even the pre-hospital staff should be able to call into the consultants, or the snake, let's call them snakebite consultants, and do a video call with them. So, and that is what they are doing, and that is the gold standard. And I think it's a first world thing that is happening here, which is excellent.
Yeah, well done, guys. So we all know what we call a snake that works for the government, yeah?
A leeslang.
A leeslang. That's better than my joke, you chop. A leeslang. No, a civil serpent. All right. Do we have any questions from the floor or from the panel for praise? Wait. If you put your hand up, you stand up. You get the camera on you, and you get a microphone.
Thank you. Just a quick question. Is it possible that we can contact Luke Commission direct, or does it have to go through TIA? And which number would we contact?
Yes, you can always contact the Luke Commission. We have a hotline. Even directly we can do so, because once you do that, we also do contact there. So it's still okay. The number is 7613-8814. 7613-8814. 7613-8814. That is our TLC hotline.
Anybody else? You guys all right? Shall we? Oh, you got a question? You've got a lot of questions. You said you were going to do this.
Okay, this one goes to the doctor there. Okay, I just wanted to find out quickly on the neurotoxic snakes, because you say some of the patients, they end up like coming to the facility and they are sometimes say they may be drunk. I just wanted to find out, does any neurotoxic, what you call it, venom, would in your breath come out as like you've been taking something like alcohol or something?
So let me understand your question. Is there any type of a smell that a neurotoxic patient would give off, like somebody that has taken alcohol, that you can physically smell them?
No, that doesn't happen because it doesn't. You need to have a breakdown before you can get the smell of alcohol. So you can get it, for example, with somebody who's a diabetic or something like that smell very similar. But with the venomous snakes, that doesn't happen. But the problem is we see a large percentage of the people that get bitten are one of those who go, I've seen this on TV, hold my beer. And that's when they come in. The problem there is that their symptoms are almost exactly the same. You've got slurred speech, you've got ptosis, you've got ataxic gait, you've got all those symptoms which are the same, and you don't know if they're drunk or if they've been envenomated. The only advantage that you have is when you're drawing blood oxygen levels, it doesn't hurt because they don't feel anything. But for the rest, it's a nightmare to actually deal with those patients because you don't know if you're succeeding or not.
Bongi.
Okay, so I also just wanted to add to that response. So the most important thing, like Dr. Hugo had presented, if they're drunk and they get bitten by a snake, they come to the clinic complaining of being bitten by a snake. They have that history, but they're also drunk. So it might be a picture that you're not sure of. The most important thing is your monitoring. So you monitor their carbon dioxide, you monitor their saturation, you monitor everything, your vital signs and everything to make sure. So basically, what is important is not really how they smell or how they present. It's important that if they come to the clinic, you monitor them and see how they progress in terms of symptoms.
Oh, here we go. Can you be upstanding? Thank you.
All right, thank you so much for these presentations. I'm curious to hear more about the telemedicine system that you guys have in Eswatini. Who's calling? It seems like Tia is answering a lot of these calls, both from doctors and also from patients. But is she training anyone? Is there any sort of toxicology system that people are trying to set up? Yeah.
It's a good question. Do you want to answer?
Okay, so on the telemedicine aspect, as at the Look Commission, we do almost everything digitally. And we do invite you, if you'd like to see some of the things, to experience how the hospital is run on a digital platform. So when we talk about telemedicine, we mostly are saying, we as the Look Commission, we use Slack to do most of our communications, and also like these calls we are talking about. So Thea is one of the hotlines as well for snake bite victims, as well as the Look Commission hotline for snake bite victims. It's a hotline, and so when someone calls, it immediately alerts senior doctors at the Look Commission, and once the senior doctors are alerted, they review whatever is there. If there's not enough information, it's a follow-up call to whoever has reported the snake bite, so that we hear what the patient has and symptoms. And once you know the symptoms that they have or the time of the bite as well, you can now try to make decisions and see, do we need to send an ambulance with airway? If you just hear maybe swelling and all that, you may think about progressive painful syndrome. So you may say, let's send an ambulance, but maybe only with EMS teams and all that, not necessarily a doctor. But if you now hear probably there's perioral numbness, there's ptosis and all that, is not able to speak or difficulties in breathing, decisions are made like that. So that's kind of how we handle the telemedicine aspect of it. And as well as monitoring the snake bites even in the hospital, Thea can also give a testimony of how on the hour, every hour, there is pictures of the snake bite, especially cytotoxic, how is the swelling progressing and everything. It's monitored, and the medical team has access to that. So the doctors attending on the ground and the senior doctors who may not be on the ground, depending on who is where, they still give oversight to say, oh, looks like that swelling is progressing pretty fast. May we talk to Thea? May we talk to this person? Let's find out, do we now need to give antivenom in this and all that? So it's the collaboration there is mostly being done digitally, and it's a very good tool in this modern day world that is helping to save lives.
I just want to commend him on actually what I saw, what they did here is it's actually a first world stuff to have a team of senior people overseeing other people and them not feeling that they've been watched the whole time. So some of the best surgeons in the world, for instance, have got someone watching them the whole time, and they invite that. Overseas, when we do, you saw ECMO is my thing that I like. Overseas, the ECMO service works like this. The doctors that goes out to the ECMO will have other doctors on video call watching them and giving them advice, because you get tunnel vision. And to get it, I have a team of senior people is actually, that's what first world medicine is. I mean, I think, not to put us down, but I think we sometimes struggle in South Africa with this problem, is that one person thinks he cannot learn from another person, and you have this thing of this teamwork, or people that has done 1,000 snake bites, so they can give you proper advice. And this is the way to go, to have a team that monitors, and you can call and you're not scared of those people. And I think that's the first world way of doing medicine.
Hugo, I like what you pulled out of that. Egos. You should have a big enough ego to be able to let others in and advise.
Biggest killers of patients, egos and hypoxia.
Okay, so I'm going to just summarize this whole snake behavior, snake fang story. A viper type of snake, 90% of them are ambush hunting snakes. They will sit in one spot, rely on their camouflage, their keeled scales, everything within that specific animal's design is to sit and wait for food to come to them. They do not have that lucky decision to have the opportunity to go out and choose thin-skinned prey like frogs and rodents. They need to be sure that anything that comes across their path, they have an extension of fang, whether it's a thick-skinned animal, a thin-skinned animal, or a lot of these huge viper snakes eat a lot of ground-dwelling birds, pheasants, partridge, things like that. To get through all that stuff, to get into a cavity or a lymphatic tissue deep enough to be able to immobilize that thing. And so it goes around snake behavior, but also exactly what you said. Okay, so well done on that. We are now going to have, we do have a question session. So we do have a question session. Does any, huh? That's right now. And then we're going to have tea. So just tea and snacks are right at the back, in that back corner there. There are 2 toilet facilities. If you go literally right to the end of this building, to your right-hand side at the back, there's toilets there. And then also inside the snake display facility around the corner here, there's also a toilet facility there. Please feel free to use those. But are there any burning questions? We've got about 5 minutes for burning questions. Are you going to do it on WhatsApp?
I'm not going to answer, but I can ask. Ask the panel. I can't. Okay, so we've got a question here. Do we have portable nasal carbon dioxide monitoring that can be used in small clinics? Yes, we're asking if there is, yes.
So yes, you do get them. They're available. It's like a little pulse oximeter, and they normally do pulse oximetry. They do pulse oximetry and nasal or EtCO2. So it's Nonin has got one, and there's multiple. I think every Chinese company makes one. So there is EtCO2, nasal cannula, and saturation in a small. Well, but I don't know if the question is, do you have it here? So are they available? That's it. Yeah, so I think that if he knows where we can get, I think we can put on the website where it's available.
So yes, if you manage to get those and you acquire them, it is good because they are standard and they can monitor well. But as well, to help yourself even now, as you are in the process of acquiring those, what we do is sometimes you get your water tap cable and you connect it to a cannula. You just remove the needle, connect it to a cannula, and you tape it. If it's to the mask, to the face mask you have, or the nasal cannula you have, you just connect the tip and tape it there. Usually you get your capnograph reading well enough and you can monitor. But this is just something you can do in the meantime as you are getting the standard thing.
Another question, at what point does antivenom administration become obsolete? They've heard that in clinics it can be used days after being bitten by the snake, or is it 24 hours later is that antivenom now obsolete?
Could you hear that? Did everybody hear? Okay, hold on.
At what point does antivenom administration become obsolete? They've heard that in clinics they give antivenom after a few days of after being bit, or others say that after 24 hours antivenom is now obsolete.
I would just like to emphasize that this question must be from somebody who's online. It comes from the United States. Oh, hello, you here? Hello, Chloe. I didn't see your number. Okay, thank you. And
Do you have to answer the question?
no, well,
Answer that one. So the antivenom question, how long can you give it after a snake bite? It is a little bit species dependent. So for a Mozambique spitting cobra, like there's a case to say that 12 hours afterwards it's already useless. While for a puff adder, you've got cases where 4 days afterwards antivenom was given and you've seen a difference in the blood results that the antivenom neutralized the venom. So it is a bit species dependent. My advice would be talk to someone that's got experience with snake bites and they can advise you.
Okay, last question from Imlamuli Rhodes was, does the potency or effect of venom differ between juveniles and adults?
Does the potency of venom differ from juveniles to adults?
Yep, in a big way. Juveniles are, their venom is adapted for their specific diet. So if you take something which is a small tree-dwelling snake, the babies are going to be eating geckos and frogs. As they get older and they're big enough, they'll start taking rodents and other mice. So depending on which size bites you, the venom could be different. The amount of venom is also going to be different, because let's say we take a cobra of 20 centimeters, his venom gland is going to be a bit bigger than a match head. You take one of close on 2 meters, he's going to have a venom gland that size. So the amount that he can introduce is that much more, and they are more powerful. But just because a baby gives off less doesn't mean that it's a harmless bite. If you take a green mamba and you milk it, a baby green mamba's venom is 3 times more potent than an adult's. Adult green mamba's venom is 8 times the yield of the baby. So either one's going to kill you. So don't mess with babies, don't mess with adults.
we find the same thing here in Eswatini. The most complicated black mamba bites are usually those from the juveniles, the younger species. They are the most complicated. They're the most rapid. We've got minutes to deal with that bite. So I agree 100%. Don't think because it's a baby you don't have to hassle. You actually have to react faster, especially with the neurotoxic snakes. Thank you.
Okay, one more.
I did ask this question prior to someone private, but I just want to ask now. Is there any way to test if you're allergic to any specific type of venom without actually being bitten by the snake?
I can see the smoke rising. Yeah, there's smoke coming off the solar panel over here.
Okay, let me take this one as well then. There are apparently tests that have been done, and it has been done in South Africa. They've tested people and they've said, okay, according to their test results, you're not going to have an allergic or anaphylactic reaction to snake bites. And then because of the fact that they injected them with a small amount of venom, that actually caused them to become allergic, and the next time they had anaphylaxis in any case. So that's why we don't want to introduce any venoms into you, because you can, after a single exposure, be allergic to it. So to test for allergies is very difficult. However, if you're working with snakes, or you come across snakes quite often, and there's, for example, spitting cobras, these are the worst of the lot, because the venom itself aerolizes. You go and breathe it in, it gets stuck in your mucous membrane, you do absorb some of it, not enough for it to be serious, but your body starts getting triggered. And then one day you're going to take either a full spray in the mouth or a bite, and then you're going to drop as if it's the worst bee sting allergy you've ever come across. So it does happen that some people build up allergies, other people build up immunity, and it is safer just to avoid getting bitten. I'm a sissy. People laugh at me. I don't like getting bitten by anything. I couldn't care if it's a herald or not. And I know of people who've been bitten by, for example, things like scalp stickers and heralds, which are not dangerous, and then their first bite from a more dangerous snake like a Mozambique spitter, within 5 minutes they need to be intubated, they need to be get adrenaline, and in that way they recover. So you can get tested, but the testing might actually stimulate the fact that you're going to be allergic in the future. Okay, snap.
Right, ladies and gentlemen, thank you for your attention this morning. We will all be hanging around as well. If you've got something else, if you're a bit shy to ask your question out aloud, then yeah, you're welcome to enjoy tea time. We'll see you in 15 minutes, I think it is, yeah. 20 minutes.